shall now go on to our next speaker, Dr. Rupak Roy, who is a Senior Consultant, Vitreoretina Services at Shankar Nethralaya, Kolkata. On to you, Dr. Rupak.
Am I audible and my slides are visible?
Yes.
Yes, sir.
Thank you very much, ARC, for this opportunity. I'll be speaking on OCT angiography artifacts. So if you look at the prevalence of OCT angiography artifacts, it's very common. In some cities, it's up to 70 to 100% in imaged eyes. So it could be patient-related, software-related, or operator-related. So patient-related could be motion artifact, software-related could be segmentation and projection artifacts, and operator-related could be defocus artifacts. So what are motion artifacts? They are basically happens due to eye movements, and the software then goes on to correct, does corrections for the eye movement, and we get artifacts. So it is very common to see such blink lines when the patient closes their eyelid. So you can see the blink lines here. Also, due to displacement, we can have linear black lies and distortion of the vessels, which are again types of motion artifacts. Another type of motion artifacts that you can see, as you see here, are doubling or non-overlapping multiple images, which are again due to software correction. Quilting is another type of motion artifact where you get crisscross structures and due to multiple saccades. Another type of motion artifact that can be seen is the banding, which can be due to the corneal refractive shift due to blinking and part of the image goes out of focus. Now, one of the most commonest artifacts that we encounter in OCT angiography is the projection artifacts. So projection of superficial structures on deeper layer. So superficial vessels reflect back to the light of the camera, the remaining light, which is RP. Decorrelation at RP mimics superficial vascular bed. So this is an example from one of our papers where you can see this is the devascular plexus where you don't expect to see this kind of vasculature. So this is a projection artifact. Nowadays, most of the machines have this projection artifact removal software, which can help us in reducing these projection artifacts. Similarly, here you can see there are a lot of projection artifact. And when you remove the artifact, you can clearly see the CNVM. So coming to the most clinically affecting artifact in OCT angiography, that is the segmentation artifact. This occurs due to misidentification of the retinal boundaries and showing structures of different layers. So before we go into the segmentation artifact, we have to understand how the OCT angiography slabs work. So each slab is generated by selecting an upper and lower boundary. The vessels that lie within these two boundaries are projected to produce an en-face image, and algorithms automatically detect predetermined retinal boundaries based on distinguishing characteristics such as reflectivity and texture. So, but there are pitfalls. Our segmentation algorithms were developed by imaging healthy eyes with distinct retinal layers. Disease pathologies such as fluid seen in DME, drusen in AMD, and even myopia can drastically alter retinal anatomy and cause segmentation errors. So what are the sources of segmentation errors? They're epiretinal membrane, macular edema, ischemic retina, where you have altered reflectivity and RP elevation. So I will, so what are the ways to correct segmentation error? This could be slab selection or manual segmentation. Coming to one of the clinical situations here, this is one of our patients where you can see, this is a structural OCT. You can see there's a double layer sign and subretinal fluid. But you go to the OCT angiography tab, this is a hydraulic spectralis machine, but you are not able to see any neovascular network. So in these cases, you can do manual segmentation and you can do a manual selection of the slabs. This is available in all machines. This is what I'm doing in a Heidelberg machine. I am manually selecting the slab here. I can do that. And now this is the slab thickness that I have decided on, and I'm slowly pulling it down to investigate the retina in a much better way. And you can slowly see a neovascular network that is emerging here, which was not seen in the default tab. This is another case. Coming to another case, this is a case of a lady with the parafoveal telangiectasia. This is a multicolored image which shows the reflectance abnormalities. And this is a structural OCT, which basically shows a hyperreflective space. And I go up and down, you're not able to see any CNV complex here. But strikingly, when you do the OCT angiography in this patient, what we are able to see, this is the default OCT angiography tab. And you are able to see a large network here, which is not correlating to what we are seeing in the structural OCT. So in this case, again, we do a manual segmentation, and as we pull the cursor down, you see this signal is emanating from the choroid. Because of the thin retina, the choroidal vessels are actually being seen as a network, which is not a true network. And coming to my last video, this is a case. This is a case of CRAO. This is a multicolor image. And if you see the OCT, you see the reflectivity of this is widely altered. So if the reflectivity is altered, the OCT angiography is not able to segment. And here we have an option of segmenting layer by layer in the Heidelberg. If you see the IPL segmentation here, it is way off the mark. So it should be somewhere here, and it has gone here. So you have the option of correcting the segmentation error manually by drawing a line where the IPL should be. But the problem is this approach is you have to do it for every B-scan slide to get a composite picture. So in a nutshell, these are the basic errors that we can see, artifacts that you can see in OCT angiography, and understanding them is important to interpret images to come to a clinical decision making. Thank you very much for your kind attention.
Thank you very much, Dr. Rupak. Srinivas, could you take a question? Srinivas, are you there? Yeah.
Rupak sir, wonderful talk. It's so difficult topic that you covered it in 8 minutes. But again, my question still remains is, see, to do one layer itself, you might have to segment it 10 times or sometimes up to 50 times. So in the busy clinical practice, I still, how do we do this? Any quick tips that we can do that, or is there any new softwares which are coming to do it? Individually doing the Brooks itself, sometimes it might take so much time. You might have to do 10 or 20 or 30 each layer, slab by slab, slab by slab. So
yes, so Srinivas, you are absolutely right. In a busy clinical practice, it is extremely difficult to do slab by slab correction. But what we can do is that manual slab selection, where you can select a predefined narrow slab and then take it up and down throughout the on-fast image to identify the vessel structures better. But still, in a clinical practice, sometimes it is not possible.
Jay Boss, any quick tip?
I was wondering that why do you want to see all 10 layers? You just need 2 layers, right? You just need 2 layers. So pick up SCP and DCP, that is enough for you. But now the segmentation algorithms are superb, and even the Plex Elite provides fantastic segmentation. I think the most important message from Rupak's talk is that, I think that OCT angio actually confuses us more, which leads to unnecessary treatment and unnecessary diagnosis. So it's better to, follow Rupak's talk and do not diagnose CNVM unnecessarily. That's all I would say.
Dr. Ritesh and Dr. Mudit, just one word from you all.
Yeah. So to one quick comment, Jay very rightly said, most of the confusion happens when we are looking at choroidal neovascular complexes. In the newer machines, we, instead of looking at the normal, the choroidal cut, just take the RPA fit scan, and you will be able to pick up lesions much more quicker. You need not go through all the scans that's just one small tip. You can try and pick up RPA fit scan and just try and see that.
Dr. Mudit?
No, I think nothing else from my end. Ritesh and Dr. J have already covered most of what has been done. And Dr. Rupak, great talk, seriously.
Yeah.
It's important to understand these artifacts. Otherwise, we'll end up erring most of these times.
Yeah. So
I think I'll make a comment, quick one.
Yeah.
Just like Ritesh mentioned that we can look at the RP fit, but sometimes the example which Rupak showed, which was in case of Mactil, those are the ones which have those new vessels very close to the pigmentation, or they can have it in the avascular slab. If you just use the RP fit, you may miss them. But again, as Jay mentioned, 1 or 2 slabs you need to identify and look carefully at that. Very good talk, Rupak. Thank you.